Yep. Does anybody have any questions for me? Anything to do with manual therapy or the course or exams or whatever you want? No? All right, good. I actually trip over pins here and I can't find it when I'm worn. Okay. All right, so I thought what we do today is look at some lumbar conditions and see if we can figure out what's the easiest way of diagnosing them. Typically, I'm pretty sure you've been taught the same way as I was. We've talked about this before, but let's do it specifically now for some conditions. So just a quick introduction. You were taught that you need to take a full history and then do a full objective exam and then come to a conclusion on what the diagnosis is. Is that pretty much right? Okay. How's that working for you? The problem with that approach is you basically get overrun with information. You get way too much. Most of it is irrelevant. So let's have a look and see how we do with some of this. Okay, so we've got 6 lumbar conditions there. Central spinal stenosis, lateral stenosis, spondylolisthesis, a pulse stress fracture, pathological fractures of the vertebra, and biomechanical dysfunction. So what I want you to do is just write down, we're doing the first one first, and then we'll go from there. Write down the diagnostic criteria that you would use to diagnose somebody with central spinal stenosis. Okay, scribble it down on a piece of paper so you commit to it, and that's what I need you to do, is commit to it, and then we'll see how we do. Right? If you don't commit to it, later on your brain will fool you and you say, yeah, I knew that. So we'll find out. If you write it down, you can't do that. All right, it's a nasty thing to do, but there you go. Not detailed, just list it. You good? All right, let's have some of them then. Harsh, you're up on the top of my list. What's your first one?
Sorry, I was just writing biomechanical dysfunction.
No, central spinal stenosis. I need just diagnostic criteria. Give me one of them.
Pain and numbness to both sides of the leg, radiating down.
Okay. So bilateral pain and numbness. Okay. Nanny?
So I had stiffness with joint mobs like PAs. You'd also have decreased range of motion, like active range of motion.
All right, you gave me 2. So which range of motion?
Well, if it was central, would you have generalized lumbar range of motion decrease?
You probably would, but what would dominate it?
Extension.
Okay. Christy, if you're wondering, I'm going on the order on which you are showing up on my screen, all right?
The first thing I had was bilateral neuropathy or peripheral neuropathy. And then number 2 was just pain with extension.
Okay, I only want one because we should gather enough.
Okay.
Bilateral neuropathy.
Yeah.
Let's change it, can we? It's not a neuropathy, is it? It is, but it's not what it's called. It's radiculopathy, yeah?
Okay. Sorry, that course I just took was all about neuropathy. So that's why I'm on neuropathy.
Yeah, I know. Technically, it is a neuropathy. These are lower nerves. So technically, it's a neuropathy. And all the signs and symptoms are almost the same. There are differences, but we tend to term it a radiculopathy. The major difference between a neuropathy and a radiculopathy is that with a neuropathy, if it's bad enough, you can get paralysis and anesthesia.
Okay.
And areflexia. With a radiculopathy, you don't, because of the multi-segments innervating that particular muscle as area of skin. Okay.
Perfect.
Okay, Viv.
So for these ones, can we add like symptoms as well, or like the history?
Yeah, sure.
So usually like insidious onset, no history of trauma. Tend to be older age, may have a history of arthritis.
Okay. All right.
And then bending.
That's good. No, it's so good for the minute. Give somebody else
okay.
a go. All right. Nicole. It gets difficult when you're at the end of the list, doesn't it?
We'll see what I can add here. One of the ones I've noticed is typically onset of pain with like walking or how should I put it? Like in more of
Extension
cone
activities.
Yeah.
Yeah, extension activities. Yeah, good. Michelle.
Generally prefer sitting.
Okay, so we've got extension activities make it worse. Flexion activities may decrease the pain, yeah?
Yeah.
Okay, you're last up, Thomas. What have you got?
Yeah, all the above. Then do you need special test to like the bicycle test or the inclined treadmill test?
Okay, we'll talk about that. All right, anybody got any more? That's all of you. What is it? You got nothing to do on Saturday? It's a bigger group than usual. That it? Okay, well, let's look at these one at a time. Certainly the pain is going to be, well, it's going to be bilateral, and it's probably going to be central as well. If we're looking at this being the central canal that's in trouble, then it's probably hitting the dura centrally as well as peripherally. So you're likely to have central and bilateral pain. All right. If this is just bilateral pain and not central pain, what you may have then is bilateral lateral stenosis. Not that it really matters that much, you can treat both the same way anyway. There may not be numbness, it depends on how bad the stenosis is. Yeah, if we've got bad stenosis, then the nerves, the spinal nerves and roots may be more affected, or the canal may be more affected. But if it's not that bad, you may get no neurological involvement at all. Fair enough? Certainly stiffness on PA, you would expect that, and it's probably going to be generalized. Even if only one segment is what's giving them the trouble, the whole area is likely to be stiff. You good? Hi, Bella. What we're doing, Bella, is distinguishing some of these conditions. Yeah, okay, range of motion. I mean, this is degenerative, so most of the movements will be affected, if not all of them, but the dominant one by a long way is extension. Bilateral radicular stuff, again, it really depends on how bad this is. Don't forget, this may not be radicular, this may be a plexopathy, so you may end up with a cord recliner signs and symptoms. Yeah, it just depends on how bad it is. Which I have to read my writing. Insidious onset, yeah, almost certainly. However, if they have trauma, then it may kick all this off. All right. So the problem you've got is we're saying it's not a traumatic condition and it's an insidious onset. It's not necessarily true. It may be a sudden onset with some degree of trauma. You good? Age, yeah, okay. So we're looking at older patients. Now, this is true providing you're not thinking about the size of the canal and the shape of the canal. If you've got a trefoil canal where you've got really severe encroachment on the lateral recesses, then you may end up with a bilateral lateral stenosis and possibly a central stenosis earlier than you would do if you had a normal canal. In fact, it can be much earlier. So depending on the congenital anomalies in the area, this can be early or late. History of arthritis, not necessarily. Not necessarily. This may be part of a generalized osteoarthrosis, but it may well be on its own, and it may be confined to the spine anyway. Right? This depends on what they've been doing and how long they've been doing a stupid thing for. Extension activity should dominate this. So walking fast, but not walking slow. Walking downhill, but not necessarily walking uphill. Okay. Flexion activities may help the pain. It may not bring the pain on. So if they've already got the pain, then yeah, they prefer to get into flexion generally to ease it off. And flexion activities probably won't bring the problem on anyway. So the preference is towards flexion positions, flexion activities. Bicycle test is an interesting one. So let's look at this. And how many of you know what we're talking about here with a bicycle test? Is this taught generally in school? It's got its issues. What are you trying to differentiate here? You're trying to differentiate stenosis from claudication from what, a disc? Is this where you're going with it? Or have you been told something different? So it is okay. You try and differentiate those three things by putting them on a bike and cycling. Yeah. Okay. So the first question is, what sort of disc problem are you trying to differentiate? Herniation?
Yes, like a bulging disc problem.
Yeah, that doesn't really do it. So a bulging disc can be a prolapse. It can be a protrusion. So where are we going with this? Which one?
More problems.
Like
More prolapse?
Prolapse.
Okay, if this is a prolapse, there is no diagnostic difficulty. If they have a symptomatic prolapse, they got severe back, severe leg pain, it's almost always unilateral. And if it's not, your concern now is it's been moving into a cord recliner problem. So trying to differentiate out the disc herniation, the prolapse or the extrusion, isn't a problem for this. It stands by itself. There's no mistaking what it is. So this is completely against what Mackenzie's group are teaching, and they're completely wrong in this. Okay, you do not get rid of a disc herniation doing push-ups. You're lucky if you get rid of it at all. But the only thing you can do with the disc herniation is try and reduce the inflammation, because you can't mechanically change that disc herniation. So what's known is that nearly all of the pain comes from inflammatory processes around the disc. So if you can reduce and we're not talking about radiculopathy now. I'm talking about disc herniation without a radiculopathy, because if it's got a radiculopathy, there's no doubt about what it is. So if this is a disc herniation without radiculopathy, nearly all of that pain is caused by inflammation. So your treatment is to reduce that pain, reduce the inflammation. This isn't one that needs to go on a bicycle. If we're talking about a protrusion, nobody really knows what a protrusion looks like. This could be a segmental dysfunction, but what you're probably going to get is a positive straight leg raise with it. But this isn't going to behave like a disc herniation. So it's really not meant for this. So that leaves you now ischemia, intermittent claudication, and stenosis. The fact is that most stenotic problems do have an element of claudication. But if we're talking about intermittent claudication affecting the muscles rather than the dura, then sure. But your history also gives you an idea of this. In fact, what I should have done was put it on here. I don't suppose we're going to have time for it, but I'll stick it on anyway and see how we do. Into 3, I mean, there you go. They're going to tell you their main problem is walking uphill, not downhill. This is not going to be an extension problem. This is going to be a demand problem. So whenever they make demands on the lower limbs is when this symptom is going to come up. It's also going to be unilateral when it's in its undiagnosed state. Now, they probably will have sclerotic problems in both limbs, atherosclerotic problems in both limbs, but one side is worse than the other, and you'll get it unilaterally, and it stops you from doing it. Okay, so you never bring the ischemia to the other leg, so it's unilateral, not bilateral. So you know it's not central stenosis because it is unilateral. The other thing is they've usually got some evidence of peripheral artery disease anyway. If you look at their legs or you talk to them, they do tend to get discoloration changes in the feet as part of this. Now, you can get isolated claudication into the buttocks or the calf in particular, sometimes into the quads, because of local ischemias to some of the arteries that supply those muscles, in which case, if this is gluteal, for example, this bicycle test isn't going to do it for you. But what you've got now is calf pain, not leg pain. So honestly, this really doesn't need to go on a bike. Yeah, this is armchair quarterbacking, basically. Somebody's dreamed this up. And I can remember when this happened. It was decades and decades ago. Well, this is a good idea. We can put on a bike and we can differentiate between the three. And basically, if you think about it, you really don't need to. If you want to figure out whether they've got a claudication problem, let's say it's in the calf, you lay them on the bed and they just do this with their feet, plantar flex and dorsiflex, and as soon as that pain starts on one side, you let them stop that side and keep going on the other side. And the chances are they'll then get the pain on the asymptomatic side as well. All right. So this bicycle test really isn't that necessary, if it's necessary at all. You good? So if we're looking at making this a shorter list, because with all of those things, yeah, maybe. The problem is you can have somebody come in who's youngish, 40 with this, because they've got a congenital anomaly in the spinal canal, or because they've had a history of a fracture through there, and this is a bunch of callus forming there. So the age thing is generally older, sure, but it's not always older. Same with gender, it's usually men, but when women get it, they get it just as bad as men do. So these are predispositions, and it's something that you want to put aside and not make it your diagnostic criteria, because it tends to frame you and you can anchor to it. Oh, he's 75, he's got this pain, it must be stenosis, and it isn't necessarily true. It's possible to have a disc herniation at L5S1, but in particular, that in an 85-year-old that looks exactly like the disc herniation in a 30-year-old, because it is exactly like the 30-year-olds, because some poor bastards keep a fully hydrated disc right into old age. And when that ruptures, it's a disaster for them. It's not great for younger people neither. When it happens in somebody who's old, it's a real bitch, and they often die from it because they can't move around. They get pneumonia and all the other crap that goes along with it. But these are predispositions and not really diagnostic criteria. So if we had to pick from this for central stenosis, first off, it's got to be bilateral, hasn't it? Yeah. So we're looking at bilateral pain. Okay, what else? What's the degree of pain like in these on average? How bad are these?
Very bad.
They can be, but generally not. They're anywhere from moderate to severe. I mean, they can get horrendously bad, but that's an outlier. So if we're looking at the stuff that makes it, so we can look at the outliers in a minute and bring them in. So the pain tends to be moderate to severe. It's bad enough to bring them in. Yeah. Okay. What else you got?
Positional dependent.
So extension impairments. Is that what you mean?
Yes.
Yeah, okay. So it's not necessarily positional. So extension positions and extension activities. So extension. Yeah. Anything else you want from the history? Okay. Assessment. Dominance. Range of motion loss. Extension. Yeah. PAs, stiff. Is that all right? Now, what else could that be?
Will they have radiating symptoms?
Sorry?
Will they have radiculopathy as in radiating symptoms to the extremities as well?
No, not necessarily. There may be neurological changes, there may not be. We can add that on in a minute. We can look at the outliers in a minute.
Okay.
So what else have you got? What else could that be? If it's not stenosis, what else could it be? So now we're into bias and error correction. Look at it, bilateral pain, moderate to severe pain, extension problems, dominance is range of motion loss, but we've got all movements affected. PAs are stiff. Now, it doesn't matter how unlikely the condition you're thinking of as a differential diagnosis might be, it doesn't matter at all. What we want to do is eliminate it as such. So what else have we got? I'll give you one, the easy one, disc herniation. Is that okay? Central disc herniation. Now, what's wrong with that from the information you've got?
Flexion is affected too.
Yeah.
Flexion's not affected much. Yeah, that's a big one. The range of motion pattern is wrong. Also, the PA is wrong, isn't it?
Yes.
Okay, so it's unlikely to be a disc herniation. We could try and do some more tests with it. What would you want to do?
Some compression and distraction.
Yeah, that doesn't work terribly well. It really doesn't. Those tests are a bit very iffy. Compression and traction, they're very, very iffy. They're also not particularly specific. Could do straight leg raise. Straight leg raise. So if this is a disc herniation, you would expect this to be much more severe with the straight leg raise than you do with a stenosis, yeah? I mean, you've all had some experience with stenosis and some experience with disc herniation. It's night and day, isn't it? So if we say a negative, relatively negative SLR, you know what I mean? It may well be positive, but it's relatively negative compared to what disc herniation should be. So on all accounts, disc herniation doesn't look likely. Give me another one. There is one other thing with a disc herniation. There's what I'm saying about bringing in the predispositions into the bias correction rather than into the diagnosis. What's your usual age group for a disc herniation?
Younger population, or like stenosis is usually later.
Yeah, 40 or so, yeah? 40, 50 generally. Yeah, the normal age group. Yeah, the normal age group for a central stenosis is 60, 65 and up. Yeah, so unless they've got something really weird going on here, then it's that age, you would expect to see that age group there. So let's say that you did have a young person, all right, with these symptoms, a 40-year-old with these symptoms because they got a congenital anomaly. Your main problem now is this a central disc herniation? So my thought wouldn't be a central stenosis, my thought would be a disc herniation going backwards because it's a safer bet. If I look at it as a central stenosis and make that diagnosis, but then I also, and I've screwed up, and this is actually a central disc herniation because they're old, because they're older, it messes it up. So you're safer off when you're not sure, go with a disc herniation. So if we look at the disc herniation, there are a number of things here that says it won't be, and we let them off. So you could have a 40-year-old with stenosis where you're thinking that it's a disc herniation, but everything else is telling you it's not because they're 40. So what you may have now is an outlying central stenosis. So this is a matter of putting this information into some sort of context rather than just looking at the information itself. This could also be a bilateral lateral stenosis. Yeah. So we talked about that. No central pain. This is just coming straight off from the sides. It's not affecting the center of it. Otherwise, I doubt whether there's any way that you can tell clinically you're dealing with a bilateral lateral rather than a central stenosis. But as your treatment's going to be much the same anyway, do you care? The other one is already listed down there, spondylolar. And the problem you got there is the spondylolisthesis is a central stenosis. Yeah, it slips forward and it basically reduces the size of the spinal canal. Now, how far it slips determines how much effect it has, plus the fact, and it's not just that, it's the shape and size of that canal. So if they've got a very small canal or a trefoil canal again, then a minor slip can give you major problems. But typically, if they've got a normal canal, then the shift, the translation has to be fairly much. Grade 2 and less, it's probably not going to give you the evidence of a spinal stenosis. Spondylolisthesis, rather. Is that okay? So now what we got? What's the difference between a spondylolisthesis causing a central stenosis and degeneration causing a central stenosis? Severe degeneration, couple of that. What's the big difference between the two? Why
Are you
is it
talking about?
Sorry.
Just for the spondylolisthesis, are you talking about someone like a young person could have it like that does lots of extension activity? Is that what you're going after?
Yeah.
So like,
The age is a big difference between the two. Again, isn't it? Yeah. So I can have somebody very young. I can have somebody whose piles are malformed, or they've had some trauma that's separated the piles. And this comes on very, very young. This is 14, 15 or so. And it's severe, very severe. That doesn't walk into your clinic, or it shouldn't walk into your clinic. The other age group that gets spondylolisthesis are 40, 50-year-old people. So the age group helps you determine which one of the two. But again, now you're bringing the age of the patient, not into the diagnosis, but into the error correction. Separating out your diagnoses. Is that okay? Does that about do it for? It actually doesn't. There's always another one. What is it?
The facet joints, changes in the facet joints, and that is usually worse with extension.
It's very unusual for you to get bilateral facet joint problems, and they're very unlikely to give you central pain. So while it's possible, just possible, that you'll get a bilateral lateral biomechanical stenosis, it's extremely unlikely, extremely unlikely. And if you get the segment shifting rather than the facet, which you can do. So can you see my hands? I can't see me. Can you see my hands all right? So if this is front and back here, if it does that, it goes, translates across and jams up there, then that will give you central and bilateral pain sometimes. That's what a Mackenzie shift will look like. You'll just look deviated. So with central stenosis and spondylolisthesis, what you tend to see is a kyphosis. Yeah, but with a translational thing, you're going to see a scoliosis. No, I'm thinking of cancer. So secondary deposits in the vertebra. That will give you central pain, and it may well give you bilateral pain. Now you've got problems. How do you tell the difference? Age groups about the same.
Just identifying other red flags that could possibly be unrelated to central stenosis, like recent unexplained weight loss, severe unremitting pain.
That's all of that stuff. I know you get this as your routine stuff. So severe unremitting pain, weight loss, night sweats, all of that comes on about a week before they die. Okay, the reason they're getting this pain is generally because of a fracture. So the bone is fragile because of the cancer. Now the cancer can produce its own pain chemically, but often this is about a fracture, so a sudden onset. Generally speaking, you said it, this generally comes on gradually over a period of, gets worse and worse over a period of months and years sometimes. Yeah, cancers will kill you quicker than that. Secondary deposits will kill you a lot quicker than that. If it comes on suddenly, it's probably a fracture. Whether it's cancer or osteoporosis, it's probably a pathological fracture. Yeah, so this is the best you can hope for, is you can identify it by the onset and the way it behaves. Now, if this is a vertebral body fracture, this will not like flexion. Extension won't bother it, because what you do in extension, or won't bother it as much, because what you do in an extension is shift your weight to the posterior column off of the anterior column. In flexion, it compresses the anterior column. It acts like a disc, basically. So you get much more pain on flexion than you will on extension. So that's what you're hoping for to see, if this is something other than, well, you're not hoping to see it, obviously, but this is what you're hoping will show up if they've got it. Sudden onset, and often with minor trauma, flexion dominance now rather than extension dominance. Okay. Later on, you'll get all the other stuff, continuous pain, then constant pain, and so on and so on, night pain and so on. But that's generally diagnosed by that point. Okay. Lateral stenosis is central stenosis unilaterally, basically. Yeah. So let's put it down that way. Unilateral central stenosis. But there is one thing that it can do, and this is unusual, very unusual. That is, there is pre-clinical stenosis. That is, there is no symptoms of it and no signs of it. If they haven't got symptoms, they're not going to have much in the way of signs. But there's no symptoms of it until the transverse canal, the intervertebral canal, is closed down. Now that can happen because of a biomechanical dysfunction. So if this is an extension subluxation, so it jams into extension, if this is pre-stenotic, as it were, pre-symptomatic anyway, then you can close down that stenotic canal and make it symptomatic. So this could actually be episodic. So they get back pain, leg pain, all of the stuff you see with lateral stenosis, pain on extension activities, walking downhill, rolling up, all that stuff, but it's episodic. Now, these ones are manipulable, but you have to be careful with them. You have to make sure that always you're manipulating this interflexion. That is, they do have an extension subluxation. So you can manipulate this interflexion and the pain goes away, all things being good. You good there? Okay, spondylolisthesis we've done basically. Now, stress fracturella, stress fracture. Now let's start off with, let's see, let's go down to the bottom and give you a chance at it first. Tolu, give me, list these criteria again, all right, for now past stress fracture. So what you got? Where are we? Tolu.
Hi, Jim.
Hello.
I believe from the history, maybe there could be an history of maybe osteoporosis.
Generally not. What age group is this? This is actually a stress fracture, not a pathological fracture. Okay, so everybody, what age group gets this?
About 35 to 55?
No,
40, 60?
no, this is younger. These are torsional injuries. They're often kicking athletes. It happens a lot in football players, I mean real football players, soccer players. This happens a lot because they plant one foot on the ground and they kick with the other foot and it torques it. So these are stress fractures. So you've got a history of fairly heavy training in that type of thing.
Sorry.
Now, this otherwise fits all of the other criteria of a stress fracture. So we've got gradual onset. It gets worse and worse and worse as time goes on. pretty much that's it. They will get pain on loading the posterior spine. So extension, particularly the quadrant test to that side, is likely to be painful. You're probably going to get pain on PAs. But anything that stresses that posterior column. The torque test, where you talk that one, where you actually grab hold of the T12 spinous process holder and then pull the innominate up towards you. So you're producing a torque force through the spine. Not a lot of movement because it's a straight back pull. So you slam these facets into each other. That's probably going to be painful. And you can isolate it to one segment by moving your hand down onto the spinous process of each segment and putting up against it until you hit your first positive. So you start from the bottom, work your way up once you've got a positive. Otherwise, there's not a lot to see here, but it's got exactly the same characteristics as a stress fracture anywhere else. And the group that's getting it are younger athletes doing kicking sports, mostly kicking sports, but running as well, hurdling, that sort of thing. Anything that's unilateral that involves torque, particularly extension and torque. It also therefore looks like what? What's your differential diagnosis here? Let's do this. Stress fracture. So torsion activity, torsion, mostly extension activities. Pain on torsion test and PAs, extension. What else looks like that? And I don't think you can differentiate it. Except for maybe one thing. An annular tear. Yeah. It's going to look just like that. So actually, let me do this. PAs on extension. The most sensitive one is going to be a quadrant tester. And annular tear. Now, the annular tear is much more likely to be heavy trauma, a single incidence, but it can tear gradually as well. I don't doubt whether you can tell the difference clinically between the two. Okay, biomechanical dysfunction. Same thing again, make a list of your diagnostic criteria and we'll go from there. So what you got?
There'll be limitation in the range, right? For biomechanical dysfunction.
Sorry, say again.
There'll be range limitation, reduced mobility.
Yeah, but that applies to nearly every lumbar problem.
Oh, well, that's right.
So it's got to be a bit more specific than that.
Usually flexion or extension, depending.
Sorry, what was that? Flexion?
Yeah. So flexion or extension, but most times, yes.
All right, it's flexion or extension. All right,
Yes.
it's not both.
No, I said flexion or extension, yes.
Yeah. So that's your impairment. Your range of motion is going to show the same thing, but more clearly. So they may well say that running bothers me, but if I sit for a long time, my back will start to ache. But when you look at them, they're going to have limited and painful extension, but normal flexion. So one of these movements will definitely dominate the picture, both in the history and in the objective range of motion testing. All right, it's a flexion or extension problem. Okay, what else you got? Okay, that better not be it, because we've already seen every single condition here. I think we've looked at here is a flexion or extension problem, isn't it? Central stenosis, lateral stenosis are extension dominant. Spondylolisthesis is extension dominant. Pars fracture is extension dominant. Yeah. So what else have you got for this?
Is radiculopathy absent?
Yeah, but that also applies to a lot of this as well. In fact, all of these could have no radiculopathy. So let's keep this, we can, again, let's keep this to positive signs and symptoms. Then we can use the negative ones as bias and error correction.
Okay, stiff on PAs then.
Probably not stiff. This is not that, it's not like a seriously degenerative condition. You get a biomechanical dysfunction because of local degeneration, but this isn't like the degeneration that you see with osteoarthrosis or spondylosis. All right, this is basically not imageable.
Yeah. What about pain on PAs, right, instead?
Pain on PA, yeah, an appropriate amount of pain. The PA is appropriate. So what's appropriate for a PA with a biomechanical dysfunction?
Sorry, I didn't get that.
Hmm?
I didn't get that.
What's appropriate? If we say that the PA must be appropriate for the dysfunction, what's appropriate? What's the appropriate response to a PA in biomechanical dysfunction?
More discomfort, tenderness.
Yeah, it's moderate, really.
Tenderness.
It may be painful, but it's moderate pain. So this is the other one here, isn't it? This is moderate pain. Yeah. So there's another criteria there. Moderate pain. Functional loss.
Yes. Yeah.
What sort of functional loss? Can they not function with this?
Is it usually that they can do activity with shorter periods of time?
Yeah, they could tell themselves that they elect not to do it, or they elect to do less of it.
Yes.
Because they know what's going to happen if they do too much. They're going to suffer for it. So this is non-obligate functional loss or elective functional loss. Yeah. What about objectively? We've said range of motion, PAs, anything else? Do you need anything else? What else could this be then? If we look at DDX, what else could this be? best thing is with when you're doing differentials and you're trying to figure out if you've made a mistake, which is what this is about, it's mistake correction. Have you made a mistake in what you've asked the patient and what they've told you, and have you made a mistake in interpreting this? So it doesn't really matter what differential you throw out, doesn't. So pick a differential diagnosis and throw it out there. It's your turn. I did the last one.
So you could do straight leg raise to rule out disc herniation?
Yeah, we can do, can't we? So the differential diagnosis will be a disc herniation. There's a lot to say it's not, but if you look at this now, the reason why it's not a disc herniation is because it's moderate pain. There's no obligate loss.
It's not radiation.
Hmm?
I said it's not referred. There's no radiculopathy involved. So.
Well, there shouldn't be a lot of referral with this neither. So there's moderate referral. Everything said this is not a disc herniation. Now, since where the outliers come in, let's say that instead of seeing this picture, this is an outlier. Now, the outlier will give you severe pain, much more referral, not radiculopathy, but then not all disc herniations have a radiculopathy. So there's your outlier. That's your biggest outlier. And the other thing with biomechanical dysfunction is it's typically episodic. This may be the first episode of it. So we look at this, and now look at this: severe unilateral back pain, severe leg pain, maybe moderate to severe leg pain. Okay, when it's this severe, flexion and extension are problems, just simply because the amount of pain that's being generated. Now, would you diagnose that? Would your hypothesis for that be a biomechanical dysfunction? No, it'd be a disc herniation. So now we look at a disc herniation and say, okay, what's the criteria for diagnosis of a disc herniation? And now it becomes positive straight leg raise is a must with a disc herniation, or a femoral nerve stretch, which is unusual. So we're looking at a very positive straight leg raise. We're looking at the PAs being severe, which it will be for this. And there may even be a deformity for this. So now the straight leg raise, if the straight leg raise is seriously restricted, then it's probably a disc. If the straight leg raise is not seriously restricted, then it's either not a disc or it's a contained herniated disc, where there's no bulging of the disc and all the pain is coming from the disc itself. So there's your options. This is either a contained herniation or it's something else, which might be a biomechanical dysfunction. Now, if it's a biomechanical dysfunction and there is no previous episode of this, that's unusual. So for this to be an outlier that's severe and have no previous episodes, you must be thinking of a disc herniation. So it should be imaged. And I realize that in Canada, that doesn't happen. But to be honest with you, if I was a patient and I was told this, we can treat this as a biomechanical dysfunction, and we'll try and sort you out. We'll be really careful when you see how you go in a week or two. And if you're not, then it's probably a disc herniation. Or we treat it as a disc herniation, but you can't get the MRI done now for 8 months or whatever the hell it is in Canada. Do you want to pay for it yourself? Which you can get done for what, about $800? So your choice. Do you want to do the MRI? If not, then we'll treat it. We'll try and get the pain down. We'll restrict your activities. We'll treat it like it is a disc and see if it gets better. If it gets better in a week, it wasn't a disc, it was a biomechanical dysfunction. But this isn't an easy thing. And if I was, what would you do if you was a patient? Would you get the MRI done and pay out of your own pocket? Under those circumstances? Or would you wait for a week?
Get it done if you're very comfortable.
I think I would.
Yes,
I don't think it'll change your treatment an awful lot. What are you going to do with a disc herniation, for God's sake? They're still not going to see a specialist for bloody 8 months or whatever it is.
Hmm.
You know, so you're in the same boat anyway, but I'd like to know, as a therapist, I'd like to know what the hell I'm dealing with. How bad can I make this?
Yes.
I'm not careful. So if I know there's a disc herniation, I know that I have to be careful with this patient, a lot more careful than if this is an outlier of a biomechanical dysfunction. This is your problem though. As soon as you get an outlier, for any condition, then it's probably something else. So now you have to make sure that it isn't something else and it is an outlier. Yeah. But you immediately go to the something else and disprove it, essentially, hopefully. Does that make sense?
Yeah.
So what we're doing here is we're getting into essential illness scripts, where you have very few criteria for diagnosing the average of that condition. But the trick is to come up with the hypothesis to be tested. All right. But this is basically the way it works. The problem is, my guess is you were taught probably very similar to the way I was taught, and that is you was given in the classes, you were taught this is what a disc herniation looks like, this is what central stenosis looks like, and he was given a list of things that make that up. Is that pretty much it?
Yes.
The trouble is you end up with so many things on that list, it becomes very, very sensitive, but it has crappy specificity. And you get so overwhelmed with the information. So if we can cut down the information you're getting on the average condition, it becomes much more manageable and you're more focused on the thing you're trying to prove or disprove, whichever way you want to look at it. Is that okay? I think maybe what we'll do next time is I'll come up with a bunch of illness scripts that I'll send you anyway. And you can look at them and we can discuss them and then see if we can make them better between us. All right. Now, the other thing I'm doing with the American group is I'm making a whole bunch of videos, very short videos, 10, 12 minutes each one. And we're going to introduce that in our certification program down there. So we're going to send out about 3 videos a week. And then after that, I do a Zoom session with them on the videos. So the actual sessions, the videos themselves are very brief introductions, enough to give people an area to talk around. All right. How much information can you get on critical reasoning in 12 minutes? But then we can spend time discussing it and maybe get some more information. And what I'm hoping is it will save doing this in the classroom. Or if we do it in the classroom, then they'll be familiar with it and it'll go a lot easier on everybody. Do you want to do that?
Yes.
Do you want me to send you those videos? Then we can talk around them on the Zoom session.
Yes.
Yeah.
Yes.
All right, will do. I will do.
Thank you.
All right, guys, that was fun.
Yes, it was fun.
All right. Okay, so I'll see you Sunday. I'll get the videos out to you and we'll get started on that next week.
All right. Thank you, Jim.
All right,
Thanks.
guys. Take care, everybody.
Thanks, Jim.
Have a good week.
Thank you.
Bye.
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 Enjoy your evening.